All right, guys, we are live action. Dr. Pinesett here. And today we're talking about healthcare. In particularly, we're talking about this government shutdown that is being lobbied back and forth between the Democrats and Republicans. We're talking about all the different issues. And what you may be hearing all over the internet is that Democrats want to give illegal immigrants free healthcare. And they want to drain the American taxpayer dollars. And the Republicans are saying we want to put America first and stomp on the necks of these illegal immigrants. We want to stop this cash flow to help real Americans. And the truth kind of lies in between there, but it's all kind of rhetoric and exaggeration, and it doesn't really go into the core specifics and the core issues that really matter at hand and that affect each and every one of us, from patients to students to pre-meds, doctors. It affects everybody. And so tonight, what I want to do is go through the true healthcare economics. And so that way you guys can be educated, you can be informed, and have a more nuanced and rounded perspective of what is actually happening with the government standoff, with healthcare, with insurance, with all this stuff, the Affordable Care Act, and all that kind of stuff. So we're gonna break it all down tonight. And by the end of this, you're gonna have a complete picture and be like, gosh darn it, is this really what's been going on? How come no one's explained it like this? We're gonna break it all down like we always do. If this is your first time with me, I'm Dr. Andrew Pinesett. I'm the pre-med protein expert. I'm here. I'm an anesthesiologist. I'm an educator. Y'all worked with us for over 20 years. And on this channel, I'm always bringing you the information you need to be educated, to be empowered, and to create independence in your life, to make the right decisions to get you where you want to go. And if you're trying to go to medical school, or if you're in medical school and you're in medicine, it's very important you understand these issues so you can advocate for your patients appropriately, and so you can inform people about how this stuff works. I'm all these things. At the core of this, though, I'm uniquely situated to talk about it because I'm not just a physician. I actually have my master's in public health, so I've studied the public health side, but more specifically, my public health degree has a focus in health services management, which means I have a healthcare business degree. In addition to that, I worked in healthcare consulting on multiple angles, working both from the workforce side and training workforce. I've worked on the Office of Statewide Health Planning and Development, talking about hospital development and hospital economics. I've done hospital redesigns. I've done clinic redesigns. I've done insurance enrollment and outreach. And so I've worked on a lot of different webs of this healthcare system. So not only have I studied this stuff, but I've experienced it firsthand. Now you fast forward today, I am a practice owner. And so as a practice owner, I have to set my rates. I have to bill insurance. I have to deal with claims. I have to do all these things. And so I am truly entrenched in all the economics. So tonight, we're gonna get a real perspective. I'm gonna hit the introduction. As always, we're live action, y'all, live action. So if you are here and you're ready to learn, like the video right now. If you have questions about this topic or any other topic, put them in the comment below. I'll make sure at the end I answer all the questions that are in the box so that way you guys get the answers you came here for. I thank you for joining me. Let's hit the intro. Let's get right to it.
Today is the day, guys. You're going to take your future into your own hands. You're going to dominate. You're going to be successful. No excuses, just dominate.
All right, guys, thank you so much for joining me. Like I said, I'm Dr. Andrew Pinesett, and I'm here as always to educate and empower you guys. And right now, politics is everything. I feel like every single day I'm getting hit with some new breaking news story that's more outlandish than the previous, with some person making this claim and this claim, and it's like a race. It's almost like social media, right? It's like the race to who can be the most polarizing in their argument. And when we try to polarize, when we try to say it's just this one thing, we lose the nuance. Because like most things in life, nothing is really black and white, right? There's a lot of gray. And in healthcare, there's a lot of gray because of the complexity and all the players involved. And so we have to separate what is rhetoric, right, from what is actual reality. And in the headlines, you've seen that this debate is over illegal immigrants. And I want to tell you that it couldn't be further from the truth. If we're going to cut to all the meat of this, I'm going to break it all down to you. But to get to the thesis of this, it is a flat out lie to say the government is shut down right now over healthcare for illegal aliens. The Republican Party, whether Democrat or Republican, listen, right? What are the motivators? The Republican Party understands that its base is all about America first, and they see, and they have been able to radicalize and use illegal immigrants as a symbol of un-American and a symbol of everything that's eroding this great country. And so in every issue, they try to find a way to work in illegal immigrants, undocumented, criminals, right? Rapists, coming across the border in droves, bringing in the heroin, serving up the opioids, the fentanyl, all these things, because they know when certain people hear undocumented illegal immigrants, it rallies them. And everything else is lost. I don't know what the issue is, but forget them illegal immigrants, and they rally to it. And so they're using that as a ploy to mask what's really going on. So let's talk about it. Are the Democrats trying to give illegal aliens health care? Are Republicans trying to stop illegal aliens from getting health care? The answer is false. This has nothing to do with that, like I said. And it's because we're talking about Medicaid, government insurance, and government subsidizing healthcare. And the argument is that if we allow illegal immigrants to have Medicaid, then the taxpayers are paying for it, the government's paying for it. But the reality is that undocumented people in America are not eligible for any federal health programs. Not Medicare, not Medicaid, not Affordable Care Act, and the subsidies tied to this. And you might have seen a flurry of things talking about the Affordable Care Act subsidies going away and people seeing their premiums freaking double, triple, and quadruple. It's crazy. But illegal immigrants, undocumented people, are not eligible to enroll in any of these programs. So to say that Democrats arguing about healthcare are trying to give these people coverage, that's a flat out lie because it's not allowed. However, and here's the nuance. In America, we have a federal law called the EMTALA. It is short for the Emergency Medical Treatment and Labor Act. And this law was put in place in the 1980s. And the whole point of it is that hospitals and certain service providers were essentially patient dumping, where they were screening to make sure that people were insured and well insured before they were providing care. There was also a history of discrimination, right? In this country, right? You look back, civil rights is in the 60s, right? Not that long ago, where you had certain groups of people who were discriminated against and they were denied care on those bases. So what happened was this act, this EMTALA, right? I'll call it EMTALA to make it short, right? This EMTALA was passed in the 80s to make sure that when patients needed emergency care, they could get that emergency care. So this law is a unfunded mandate, which means that hospitals have to provide emergency care for any patient who needs emergency care, regardless of insurance status, and there's no funding mechanism for it. So what is the downstream, the sequelae of this law being passed? It means that anybody in this whole world, regardless of whatever status is whatever, if you are a human being, you can walk into a hospital that has an emergency department. If you're shot 6 times and they have to stabilize you, they have to treat you, they have to give you the IV, they have to take you to surgery, they have to do all they can to save your life, regardless of if you can pay for it or not. So now, if that's the case, right, in this unfunded mandate, how does the hospital stay in business if they're providing emergency services for free to anybody, regardless of insurance? It's a real question, guys. We're live action, right? So when I ask a question, it's not rhetorical. I want you guys to respond because I want you guys to think it's a thought exercise. I know this stuff. Whenever I come on here, I'm trying to educate you. And so we have to really churn those wheels. We have to think about it. And then we have to comment, guys. And we have to say, you know what, Dr. Pinesett, this is my thoughts on it. This is what I see. Because that's how we learn. That's how we grow from everything that's happening here, right? If we don't do that, then we aren't growing in this process. Yes? We have to understand this. So if I ask you, and as I ask you now, how can hospitals stay in business if they have to provide care for uninsured people? Well, there is a such thing called Emergency Medicaid. Because, right, at the government level, we recognize, like, oh my gosh, if we make them provide all this care and we don't have a funding mechanism for it, all these hospitals are going to fold up. And so Emergency Medicaid allows for hospitals to apply for Emergency Medicaid reimbursement for uninsured patients. If you know anything about insurance reimbursement, government insurance reimburses the lowest, and it reimburses nickels on the dollar. And so even though a trauma might come in and need $100,000 worth of resources, the hospital won't recoup that full $100,000. It will recoup some of that money. right? But some is better than none. And so that's what emergency Medicaid is. And so what the Republicans are arguing is that this access, this ability for hospitals to apply for emergency Medicaid for any uninsured person that comes into the hospital, including who? Illegal immigrants, is terrible and is bankrupting our system and is eroding the foundation of America. But the reality is, right? Let's look at it. It's not just illegal immigrants who benefit from this emergency Medicaid. It is all of us, each and every one of us, including myself. Why? Because emergency Medicaid is not just for undocumented immigrants. Who else might come into the emergency department and need emergency care and might be uninsured or underinsured? I don't know. How about homeless Americans? How about our homeless veteran population? Are there a lot of homeless veterans who have served this country? Right? How about uninsured low-income workers who work part-time or who work full-time but don't qualify for insurance benefits? Right? How about those patients who come in to the emergency department and need emergency care? How about citizens who can't navigate because they don't have the healthcare literacy to be able to navigate the forms, even though they would be eligible for Medicaid or Medicare? They don't have the education, they don't have the know-it-all to be able to enroll properly and get the insurance they're entitled to. What about those U.S. citizens? Yes, they would use this service. What about people with mental illness who are too mentally ill to enroll in insurance? What about people who use drugs, substance use disorder, alcoholics, drug addicts who are struggling, who can't get it together, who are only that one track, and who need emergency care? All of these groups are covered in this, guys. So when we talk about the getting rid of this emergency Medicaid window, it's not just undocumented workers that suffer, it's all of these at-risk groups. And if you know anything about healthcare and medical utilization and how it plays into socioeconomic status, right? The social construct of people and the economic construct of people, you know that people who have more social instability, who have more economic instability, so they are either poor of mind, they are poor socially, they don't have the social support structure, infrastructure around them, or they don't have the monetary support, so they are poverty stricken. They are higher utilizers of health services. They tend to be sicker. They tend to need more care and more expensive care. And so you have this high utilization, highly at-risk group who would not be able to get insured care and therefore would be a liability to the hospital. Does this make sense to everybody? When these people come into the hospital, right? If the hospitals can't get emergency Medicaid, these are what we call uncompensated care or medical losses. It's just debt. It's bad debt on the hospital. So they lose money on all these cases, on all these patients. Without emergency Medicaid, there'd be no reimbursement. They need that. If we look at the percentage of Medicaid expenditures in healthcare, if we look at how much Medicaid dollars are spent, so how much the government is spending on healthcare, the percentage of that Medicare expenditure that is emergency Medicaid, what would you guess it is? All right, my people out here, what would you guess that percentage is? So of all the Medicaid expenditures in healthcare, since the Republicans are arguing that these illegal, undocumented citizens are bankrupting healthcare, what percentage, right? Because we've already said these illegal immigrants are only eligible, these undocumented workers are only eligible for emergency Medicaid, which means they present to the emergency department with a life-threatening illness and the hospital is required to treat them, right, by this unfunded mandate. What percentage of Medicaid's payouts are emergency Medicaid? The answer, guys, is less than 1%. When we're talking about billions of dollars being spent in healthcare by Medicaid, 1%, less than 1%, is emergency Medicaid. Homeless people, undocumented, uninsured, right? Mental illness, like all these things, less than 1%. So if undocumented immigrants represent a fraction, and we'll talk about how undocumented immigrants are actually a small fraction of that 1%. If it's just 1%, how could that be bankrupting? How can that be drowning healthcare? It can't. It's a lie. It's an untruth. Does everybody understand what I'm saying here? This is so important. It's flat out false. The numbers, the data, it cannot be true. When we look even further, guys, we're going to keep marching this down. If you guys are with me, take a second right now, like this video. Let me know you guys are here with me. Say, Dr. Pinesett, I'm here with you. I appreciate you. Let me reset this video. Let me get you know what you're talking about. Right now, our government is locked out. Our government is shut down. And the argument and the talking points and the rhetoric points are that Democrats are trying to give all this free healthcare away to undocumented immigrants. And the Democratic argument is, hey, we're not trying to do that. We're actually trying to make healthcare cheaper for Americans. And in this instance, right, whatever your political affiliation is, the facts are the facts. The Democrats are correct. Just telling you what's up. It's just the facts. And I'll tell you why, right? As we go deeper into this, right? We've already hit on this emergency Medicaid component in the illegal immigrant part. I want to talk about the harsh and difficult economics of healthcare and of hospitals in particular. If you guys remember, we did a video about a month and a half ago where I broke down, because everyone was talking about how physicians are overcharging and they're driving up costs in healthcare. And we talked about how that's also a flat out lie. We broke that down. Check that video out. I'll link it in the description after we finish here. We're live action right now. But we talked about how health care expenditure is a huge dollar figure and it keeps increasing every single year. And how physicians are one small part of that, and that physicians don't really control reimbursement, and so they can't drive costs. When we look at hospitals as a player in the healthcare system, there are a couple key players we have to understand. There are the insurance companies, there are the hospitals, and then there are the patients, right, who serve as a pool, who pay into the insurance, and then the insurance pays the hospital, right, and then the hospital provide care to patients. Hospitals, healthcare is expensive, and there's a lot of money going around. Hospitals aren't getting a bunch of that money. Most hospitals operate on razor thin margins in the realm of 2 to 3% profit. And if you know anything about business, right, if you've been around business owners, 2 to 3% profit is trash. It's nothing. Any blow in the wind, any downturn, and you are immediately in the red. And so it's razor thin margins at most hospitals. When you then take those hospitals and you look at a subset of rural hospitals, so hospitals that are not in major metropolitan areas, most of those hospitals actually operate in the red. They don't actually make money. They operate at a loss as a community service essentially provided to the community. They're able to stay afloat through government subsidization and through certain tax infrastructure and so forth to keep them operating to serve that community. However, despite all this, in the last decade, over 150 rural hospitals have closed, and the number one reason cited is unpaid care. Which care is unpaid in the hospital, guys? It is these emergency room visits, because the emergency room is the only time and place where there will be care that must be provided without verifying insurance first. Does that make sense to everybody? This is so important. This is very, very important for everybody to understand. If you were to call any office right now, you call any doctor's office, hey, listen, I want to get an appointment. They say, okay, great. Tell us your name. Next thing they tell you is, what's your insurance? And they run your insurance before they even schedule you. You can't see no doctor with no insurance. Come on now, right? That doesn't happen. The only place we have this unpaid care is in the emergency department. And so if you have all these rural hospitals that are operating at a loss and are closing because of this unpaid care, if you roll back this emergency Medicaid, if you roll back this Medicaid funding, if you roll back federal funding for hospitals, if you roll back that Medicare, you are going to take what is a tenuous hospital system, right? We already don't have enough access points. People talk about we don't have enough physicians. We also don't have enough facilities to treat these patients. What is going to happen to patients? What is going to happen to our already terrible, right? America ranks amongst the lowest across countries, right, for healthcare quality, despite spending the most. What is going to happen when all of these hospitals close? What is going to happen when these hospitals that have these razor thin margins are already operating at a loss operate at an unsustainable loss and have to close? We all suffer. Physicians, patients, everybody, the insured, we all suffer. Yes? This is so important. Hospital provides this emergency care. They got to keep the lights on. They got to give the IVs. They got to pay the nurse. They got to pay the doctor. They got to pay the medical aide who's there. They got to pay the janitor who cleans up. They got to pay for hazardous waste disposal. They have all these costs that aren't going to go away, but they aren't getting paid for them. So then what do hospitals do? And this is so important. This is called debt forecasting. Okay? So when you run a business, you want to do a forecast, right? So you hear in the stock market all the time, like, oh, we're adjusting our forecast for the upcoming year. To stay solvent in business, you must look ahead and say, I predict this is going to happen, and you make the adjustment in terms of supplies you order, in terms of what you do. You long-term plan the business to account for these things. That way you don't end up in negative. You want to make sure you stay ahead of the curve. So, oh, you know what? The cost of goods are going to go up because of tariffs. Okay, let's factor that into cost right now and start raising our prices. Womp, womp, womp. Okay, the cost of eggs go up, and they're going to stay up. Okay, as a restaurant, I've got to charge more for eggs. Let's add $1.50 on the menu items. That's how it goes, right? And it's the same way in healthcare. So if I'm a hospital and I know that I'm going to have every single year a certain percentage of uninsured patients, and this is a complex topic, but I'm going to try to synthesize it quickly for you guys. If I'm a hospital or I'm a provider, we talk about payer mix is a term we use in healthcare. Payer mix is if I'm a hospital or a clinic or anything, I'm looking at how am I getting paid for services, who is paying me? And you look at, okay, what percentage of my patients are Medicaid, what percentage of my patients are Medicare, what percentage of my patients are private pay, what percentage of my patients are cash patients, what percentage of my pay is uninsured care or unpaid care or bad debt. You look at all of these things. And then you always look to balance your payer mix and improve your payer mix to optimize cash flows to stay solvent. So if I'm a hospital and I'm forecasting and I'm looking at my payer mix and I'm suddenly going to have a huge increase in the amount of unpaid bad debt cases I have to do, the uncompensated care, then what I'm going to have to do is make up for that loss elsewhere in my payer mix. So what does the hospital do? Simple, right? I raise the cost of care for all the other payers. So I say, hey, listen, normally you could come in and get an x-ray, it's $500. Well, now I know I'm going to be performing 5 free chest x-rays a day in our emergency department. So I'm going to have to factor that into the cost of these other x-rays that actually are paid. So instead of $500, it's going to be $600 per x-ray. Yes, yes? If I know this I'm going to say, okay, for the across the board, I'm going to start raising these costs to everybody. This is very important. When the hospital raises costs, who pays the hospital? It's not the patient, it's the insurance company. So the insurance companies, which are for-profit companies, and unlike the hospitals, actually have much bigger margins and make really good money, they say, we ain't losing $1. We got shareholders to take care of. So what do the insurance companies do, guys? Come on now. The insurance companies raise your premiums. This is why every single year your health insurance premiums go up, because the insurance companies do forecasting and risk adjustment and say, wait a minute, we're looking at our payer mix and we have an aging population. We have people who are getting more obese, who are being unhealthy. We have people who are living through conditions they used to die from. You used to have a heart attack, it was a death sentence. Now you can have multiple heart attacks and live on. We've got great care. So they know we're going to have to pay out more. So what do they have to do? They have to collect more money to stay positive. So they raise their premiums, and that's why we pay more. Additionally, if the cost of an individual good is higher, the insurance company's like, man, we don't want to pay that. So what do? They augment deductibles. And so the premium is what you pay every month for insurance. A deductible is what you pay for a certain utilization. So an emergency room visit, for your primary care visit, for an out-of-network visit, whatever it is, for a medication. They're going to raise your deductible. They're going to raise your copay. Does this make sense? So when more people are uninsured and accessing emergency services, and hospitals receive less emergency pay, and so there's more uncompensated care, That care doesn't go unpaid. It actually gets paid, but by who? You guys. Indirectly and inefficiently. Higher premiums, higher copays, higher deductibles. Yes? And again, now I want you guys to pay attention to this. This is so important. This is the economics, the fine detail. I hope I'm not losing people here. I hope you guys are tuned into what I'm saying here. The fine detail you have to look in between there is who's most impacted by the cost of healthcare increasing, by increased premiums, increased deductibles, increased copays. The answer is it's not the wealthy, it's the middle class and it's the lower class. Why? Because, and we have to look at this, the percentage of household costs have shifted. It used to be that your housing and your food were your most expensive cost. But because the cost of premiums, deductibles, and copays keeps going up, the cost of healthcare has increased as a percentage of household income. If you're wealthy, you have disposable income. And so you can deal with a big bill that comes up. You can deal with a high deductible, right? You can handle these things. But if you are working poor, so you work full time, you grind as hard as you can, but you're making a low wage, you can't afford to absorb double the premium. You can't afford to absorb a fat $5,000 deductible when you get hospitalized for whatever happens. You can't afford your copay to go from $45 to $95. It's a huge expense for you, right? And if you guys who have ever been broke in this camp, I can remember, swear on, like, who's ever been broke here? Raise your hand right now, right? Comment in the box. When you are broke, how many of you guys, oh man, dang it, I gotta get a new tire for my car. Oh man, my computer broke, I gotta get a new computer for class. Oh. Small costs to someone who's wealthy. When you're poor, every unexpected cost seems like it's life-altering, like it's gonna kill you, like you're gonna drown under the weight of the simplest things. I remember I couldn't afford my gosh darn textbooks and it was painful. And this is before we had Amazon. I would literally go UCI bookstore, my anteaters, and I would go to the bookstore and I would go to the bookstore and I couldn't purchase the book. So what I would do is I would actually literally sit there and I would take, at UC Irvine, the way the bookstore used to be, there was multiple levels. And on the very bottom level, it was like books that were like less popular for like really fringe classes. So I would go grab the books and then I would go hide in that bottom stack and try to read those books down there, right? I would try to read those books while I was in the bookstore just so I could see what was in there and what I needed. And so I know what that is. And so the people who are hurt most by these premiums are the people who don't have the extra dollars to absorb those costs. And so again, who gets hit? The lower class and the middle class. And the reason this is problematic is if you can't afford insurance, and so this happens with me, a lot of students that I mentor and a lot of students that I coach, because they're students, right? They don't have a real income. When they're in between, transitioning from undergrad to graduate school, or they unenroll for a time or whatever's going on, they don't have insurance. They don't carry insurance, not because they don't want insurance, but because they can't afford the insurance premiums. That COBRA is expensive. So what happens? You have a larger population that could be insured, who then does what? They go uninsured or underinsured. And when people go uninsured or underinsured, what do? They don't go for their routine visits. They don't take the maintenance medication. And so what happens? They get sicker. They need more advanced care. And what happens? They then go through the emergency department to access care. I can't tell you how many times when I was on medicine services, we would have people coming through the emergency department for simple medication refills because they were uninsured. They were out of their medication, life-saving medication, heart failure, whatever. So they would wait till they were in fluid heart failure. Literally, they're drowning from the inside out. Then they would come into the hospital to get their medication. Yes? Imagine how painstaking that is. You have to wait until, okay, I'm short of breath. Ooh, I'm okay with your comment right there. Yes, I am very smart. Yes, my goodness, I am. Thank you. I appreciate that comment. Right, Dot Justice, I worked 11 hours a day, 4 days a week to pay for healthcare for myself and my two children. My husband's job only covered him, right? This is the reality for people. And so imagine having to wait until you're drowning from the inside out to go get care. It's terrible. And so what does that do? It drives up utilization, it drives up uncompensated care. So then what happens? That rotating cycle, increased premiums, increased deductibles, increased copays. How do you contain costs in healthcare? You get everybody insured. This is the argument for a mandate for universal healthcare coverage. The problem is, to mandate universal healthcare coverage, you have to have affordable options for people. And so what was our attempt to do that? I don't know. The Affordable Care Act, by subsidizing healthcare for people. How many of you guys, I don't know, how many of you guys are enrolled in healthcare through the marketplace, the Affordable Care Act? This is important. Because the insurance companies won't take a pay cut, won't cut down their profits, the government has to step in and say, as a cost containing mechanism, we're going to subsidize, we're going to provide a subsidy to healthcare. So if you guys have looked closely, if you're on the marketplace in the Affordable Care Act, they show you what this policy actually costs. This is a $2,000 a month policy. But the government is going to pay $1,000 of it to make it somewhat affordable so we can have more people insured and we can try to contain the rising costs in healthcare. Well, if we lose the Affordable Care Act subsidies, which is what the Republican Party is trying to do, is to repeal what they're calling COVID-based subsidies. Come on, y'all. It's not about COVID. It's about the fact that healthcare costs are out of control and the average American can't afford their premiums. And so the government is stepping in to say, listen, we have to save our healthcare system. We have to save our US citizens, and we have to subsidize care. Well, we're going to lose that too, guys. And so when you lose that subsidy, even people who could afford insurance, again, what? Become uninsured, become uncompensated care, become bad debt, and we get hospitals raising prices, insurance companies raising prices, and round and round we go. We get hospitals closing, we get a healthcare system collapsing, we get all of these things. And when hospitals are struggling, right, when the margins are thin, what do? We do cost-cutting measures, cost containment. We deny services. You get fewer hospitals. You get fewer physicians available at those hospitals because they say, listen, that salary is expensive. Let's see if we can get by with one physician. Let's see if we can bring in more mid-level providers. You know what? Let's do a mid-level of a mid-level of mid-level. Instead of having nurses at bedside, let's have LVNs, vocational nurses at bedside, and then have nurses supervising them. And so you get these layers of cost-cutting maneuvers that don't serve patients, don't serve providers, and really, really messes up our system. Yes? So we have to be very clear on this, guys. And I hope you guys are seeing the nuance here. And this is like across the board. This is why people fail to reach their goals, why people fail to be successful, is that they don't understand, they don't take the time to look for nuance. They don't value the details. And one of my favorite quotes is by Walt Disney. There is no magic in magic. The magic is all in the details. And for your guys' lives as students, as pre-meds, as people, we have to be detail-oriented again. That's why I do these long live streams, right? We're at 30-something minutes live action right now. Because we have to talk about details. Enough with the 7-second reel where you feel like this reel is changing my life. We have to go to the details because that's where the magic is. That's where the amplification is, right? I do long live streams, but then I also have longer courses. I also do live coaching every week. I'm gonna get on coaching right after this with my students. Why? Because we have to go down. If you want to be highly successful, if you want to be sure you're gonna succeed, if you want to be sure you're gonna maximize your potential, you have to have details. You have to know how to execute at the highest of levels. You have to have a step-by-step plan for execution. That's why I offer courses. That's why I offer coaching, because that's what gets people over the hump. Yes? If you guys don't know, get to my website, premedproductivity.com. Okay? I just pulled out of my big study course, my 5 pillars of studying less, getting better grades, which is an incredibly powerful coaching study program. I just pulled out my prime reading protocol, which is my step-by-step methodology to turn you guys into super readers. right? You guys, all the potential. If you aren't a great reader, you need to become a great reader even now in this AI times, because AI spits out text. So you have to be able to read that text, right? ChatGPT teaching mode, you just have to be able to read and sift through that and make it your own. This is the time to learn how to read, guys. And my prime reading protocol is the bomb. And on my YouTube channel, I'll have a link below the video for a discount for my prime reading protocol. So take advantage of that, guys. Get in there, learn how to read, push yourself forward. Get to my website, permanentproductivity.com. Check out my courses, elevate yourself, get the details you need to create the magic in your life to be successful, okay? So as we continue talking about this healthcare, everybody still with me? It's so important. I mentioned earlier that we talk about 1% of Medicaid expenditure is emergency Medicaid. Of that, we have homeless, we have uninsured, we have underinsured, we have mental health populations. We have all these groups that are there utilizing care. Of these groups, the lowest utilizers are actually undocumented immigrants. Why? Because if I'm an undocumented immigrant, if you guys know any undocumented immigrants, I live in constant fear that I'm going to be found, discovered, and deported. True. I'm not arguing whether we should deport or not deport. I'm just telling you the facts. Undocumented, I know people who are here documented who are worried about getting deported, right? That's a constant fear for undocumented immigrants. As a result, undocumented immigrants only go to the hospital when it's absolutely necessary. Absolutely necessary, because they have to risk being deported, so they only go when they absolutely need to go. And so as a result, they are a small fraction of that 1%. But like the other groups, when they do access care, they have worse outcomes, higher cost to us, and they're a huge strain on hospitals. So even though they're a small percentage, it's bad for everybody involved. Yes? So it's really unfortunate that we are villainizing a group that is only a very, very small fraction of healthcare expenditures and using that as a ploy to really, in actuality, hurt the lower class, hurt the middle class, hurt providers, hurt the patients who need care, and deny care from patients. It's terrible. And as we wrap up, I think it's really important as a lesson to all you guys, as future doctors. I always say, don't let people fool you into thinking medicine is not about money. Medicine is all about money, as is everything. Money makes the world go round. And you can be an effective doctor, kinda, without thinking about the economics of healthcare and about the money. But you can't be a leader in healthcare if you don't understand the systems in healthcare and the money and the economics of healthcare. So as you are future physicians, as you are pre-meds, take the time and learn about business. Take the time and learn about insurance and billing and claims and reimbursement. Look at how our healthcare system works and how dollars flow and how patients flow and systems of change, and look at and learn all these things, because then that puts you in a position where you can make real change, not just for the individual patient, but for patients as a whole. And we can truly, truly elevate healthcare and elevate and save millions of lives by fixing our system, not at the, right? We talk about it as a physician, we don't want to fix the symptom. We want to fix the root issue. What is the disease causing this symptom? We don't want to treat symptoms. We want to treat the disease. Well, in healthcare, we have a bad habit of treating the symptom, the downstream effect, when we should be working upstream at the source. And so as physicians and as future physicians, if you want to make healthcare better, if you want to really serve patients, you've got to know the system stuff and the economics, so that way you can be looking at the issues and advocating and talking to politicians intelligently, talking to your patients and educating them on how healthcare works, so that we can uplift the entire system and we can root out the dysfunction at the source and not at some mythical place that's not real. We've got to look there. And the key takeaway for all you guys about this issue, if we're going to bring it all together, is that we have to recognize that so often in life, guys, people have hidden agendas. And it's so important that we look through the muck and really see what their agenda is. That's going to reveal to you what's going on. I'm here. I don't have any agenda. I don't care one way or the other way, Republicans, Democrats. I don't care. But what I do care about as a physician, as a US citizen, as a patient, as a teacher, as a coach, I care about people's lives. I'm here on this YouTube stream. I'm here coaching with my students. Why? Because I want to make a positive change. I want to uplift. I care about people. I lead with my heart. I want people to do well. I want people to have opportunity. And so when we are looking at things, we have to look through people's hidden agendas and how they try to hide behind certain things, right? I was talking about how Charlie Kirk is hiding behind Christianity. Come on. There's more there. And Sean, I see your comments, but I'm in a flow. Can I lecture? I can't answer your question and address this lecture. I said, if you're with me from the beginning, I will answer, put all your questions in the box. I will answer questions. I'm not leaving. I will answer your questions at the end, but can I speak? Can I get at it, Sean? Can we get into it? Sean said this is pre-recorded. It's not, Sean. I see you. Sean H. I see you. Right? Deb, yes, I appreciate you. You are welcome for this honesty. Right? Ms. Hennessy, yes, this is facts. Yes. Okay? We have to look through and truly, truly understand what's happening. And we have to be open to that nuance of what's going on. In healthcare, we got a lot of issues. And I did a video about how insurance works. Look at that, guys. And look at how our system is so backwards. I did a video on physician pay. Look at how physicians are getting screwed. Watch it. I did a video about mid-level providers and what's happening there. Go watch this video, get informed, get the nuance. Because that's how you can uplift yourself and you uplift others. But if you aren't educated, guys, not, oh, I saw a TikTok, oh, I saw a reel, oh, I saw so-and-so. Look at the hard data, guys. Look at the numbers. Look at the studies. Look at what's really happening. Yes? That's what we're talking about. So your task today, I task all of you with this, is look at how am I impacted by healthcare, by insurance, by what's going on. Both now as a student of pre-med, both now as a resident maybe, right? Which is Medicaid funded pretty heavily. As a attending physician, what's happening in my practice, what are things that are changing in dynamics and so forth, right? So for me, I do a lot of pediatric anesthesia. And so because I do pediatrics and kids, that's Medicaid funding. Here in California, it's Medi-Cal. Well, my funding is in major jeopardy. I provide care to kids that otherwise wouldn't get care. And I see some of these kids, guys, I have kids who come in who are so poverty stricken, it's crazy, who are visibly soiled, who have shoes that don't fit, who have clothes that don't fit, who haven't seen a physician and who knows how long coming for emergency treatment. And it's crazy, guys. It's sad and it's disheartening. But what's crazy is even that care is at risk because that's emergency Medicaid is at risk. And I'm just thinking to myself like, man, if we start turning these patients away, what's going to happen to these little kids? I do 2-year-olds, 3-year-olds. What's going to happen to these little kids who need this emergency care and they can't get it? And you might be saying to yourself, well, wait a minute. Of course, the hospital's going to see these 2-year-olds or 3-year-olds. But there's already been a shift. And this is, again, the complexities of this. And can we bridge out here for a second? The way hospitals get around this is that hospitals will have centralized emergency departments. So wherever your area is, I want you to look. And you'll see that your hospitals around your area are a network of hospitals, right? It's a network. So for example, in San Diego, we have Scripps and we have UCSD are our two big ones. And so Scripps has like 5 hospitals in the area. UCSD has a bunch of hospitals. And if you look at all these hospitals, you'll see that not all of these hospitals, even though they're all hospitals, not all of them have emergency departments, right? There might be 1 or 2 of them that have emergency departments. And the other ones have urgent cares surrounding them. And this is an important distinction. Why are urgent cares popping up on all the corners and you see fewer emergency departments? Well, because of the statute, right, this EMTALA, emergency departments have to treat emergency care. It's a must, it's a mandate. But if I open an urgent care, I don't have to treat emergency because I'm not equipped to treat emergencies. I am only treating urgent cases. And therefore, because it's urgent and not emergent, it's a small detail, but it's big, I'm allowed to validate and verify this person is insured. And so urgent cares see little to no uncompensated care. And so urgent cares are actually big money makers for hospitals and for providers. And that's why you see a lot of privatization of these urgent cares popping up, and venture capital and so forth, and big conglomerates of urgent cares. So if I'm a hospital and I'm going to see a lot of uncompensated care, and I don't want to be, I can't deny outright, what I do is I have a network of hospitals and I close emergency departments, and I only have one emergency department and I have a bunch of urgent cares. And so everybody suffers, guys, even these young kids I treat. That's how we get it done. And it's a travesty. So everyone is hurt by what's happening right now. We got to pay attention, open our eyes, and get to the real of it, and really, really, really advocate, really speak out, and really look at the truth of the situation. All right. So I thank you guys so much for joining me. And like I said, we're live action, despite Sean. I see you. You're all good. No need to apologize. I will now switch and answer any questions anybody has. So if you have questions, put them in the box. I'm going to scroll back up to the top here and look at the questions and answer some questions. Edith, what is up? Great to see you on here. Yeah, rural hospitals struggle the most, guys. And again, you guys already see the farmers are getting hit right now. They got a lot of subsidies going on right there. This is one area will be even more hurt because, why? Because, right, those rural farmers are going to these rural hospitals, and we see those hospitals closed. Dot John says, I've been in the Netherlands. I'll pull it up. Let me see if I can pull it up. Add to there. Ooh, we can see it. I've been to the Netherlands and seen their healthcare. U.S. wishes it was so great. Yeah, so a lot of these are gives and takes, and I have a video on universal healthcare and the pros and cons of that. But you'll see a lot of that, and there's great pros to it. But I definitely think that we need to move here in America to a universal healthcare system and centralize the payers, because actually, as a provider side, I can tell you, it's very complicated. I actually don't accept a bunch of different types of insurance because they make it too difficult for me to bill. And so I have to turn those patients away to different other providers because I'm like, listen, it's too complicated. I'll never see the money back, because even though I pre-auth for the care, the insurance company's gonna make it too complicated for me to collect any money. And so it's really a travesty for people. And there's a lot of times where I'll do a service, I'll pre-auth, I'll do the service. I have supply costs, I have time costs, I have staffing costs, I have all these things. And then I can't get reimbursed in the back end because they want to argue with me about the requirement for my anesthesia. It's ridiculous. Okay. If an uninsured, I'll pull it up here. If an uninsured patient presents to the emergency department with a medical complaint, can the hospital decide to not treat the patient if they determine it's non-emergent? And so this is actually really, really important, guys. So I talked about that fine distinction between urgent care and emergent care. So how do I say this in a nice way? So this goes back to what we were talking about in the insurance video. I was talking about insurance reimbursement, how insurance companies work. Insurance companies' biggest expense is administration. And actually, there was an article that came out last week that talked about how hospitals' actually biggest cost now is administrative. The biggest cost for hospitals are administrative costs. The biggest cost for insurance company has always been administrative costs. Why? Because their number one service line is paying for care, but they're prepaid for that care. So the way that they make money is they keep that money. They keep the money that they're paid. And so the way they keep the most money is they deny claims up front. They don't pre-authorize. And they also deny claims on the back end, even if things are pre-auth. So they basically, their whole administrative function is to deny care. Well, if I'm a hospital and I know that certain care is not going to be reimbursed or is going to put me at risk of going out of business, I'm going to do the same thing. So what you'll see is a lot of times hospitals will treat to stabilization. And this is really, really tough, guys. So pay attention here. This is, again, the subtle line here. Even when hospitals provide emergency care, and that emergency care then gets paid somewhat by Emergency Medicaid, Emergency Medicaid only covers the acute stabilization of that patient. It doesn't cover any follow-up, any outpatient service, any rehabilitation, all of those things. And so what hospitals will do is treat to quote-unquote stabilization, and they will try to move that stabilization line of what is considered stable. And it's really, really, really sad. This is when you hear about people dying right outside of hospitals or dying recently after hospital admission, is that the hospital will get them quote unquote stable so that they're not critically ill, dying in that moment. But that patient is at great risk of dying in the days or weeks coming from that visit, because there isn't that follow through, there isn't that wraparound care to ensure that they actually start taking these medications, that they understand these medications, that they are optimized, that they're whatever, they're just stabilized. They're not optimized, they're stabilized. And this is the way, right? The difference is, like, think about your homework assignments, right? You might get something submitted and it might be adequate, but is it optimal? Is it the best you could probably do with that essay? No. And that's the way sometimes our healthcare works, is that we are stabilizing patients, but we aren't optimizing these patients. And that's really, really unfortunate. But so yes, the long and short of this is that emergency departments, hospitals, they have to treat people who are emergently ill, but they only have to treat them to stabilization. And what stabilization means is a wobbler. And I don't think it does patients the biggest service, but it's what is required with our current dysfunctional, broken healthcare system. So it's really, really tough. And like Dr. John says, it truly is a never-ending cycle. It's really, really hard to fix these things. That's why we have to get to the root and the nuance of all these things if we're going to be effective and we're going to really have sustainable, high-level, high-quality healthcare for patients, and a functional system for providers where providers aren't burnt out and aren't feeling like they're caught in this futile cycle. Let's see. Thank you for your comment, SJ. I appreciate that. So Sean asks, let me add this in here. How can you learn from being traumatized? And he continues to talk about this, that recently he's had a problem. His mom passed away and is having difficult proceeding with dental school. And I can actually relate to this. So thank you, Sean, for asking that question. I can relate to this because I have a medical assistant who works with me, and I like to create opportunities for students, like I said. So I always make sure that my medical assistant who works with me, I call them an anesthesia assistant. They assist me in all things anesthesia. They take pre-ops, they take vitals, they assist doing IVs and doing airways and all that kind of stuff. It's really an awesome position working with me. I always have one of my students working with me. So a student who's enrolled in my courses or my coaching that I get to know, whenever I need an assistant, I send out an email to my email list. I say, hey, listen, anybody interested in working? And I pay them. And so it's great experience. It's paid experience. I write them a letter of recommendation for medical school. It's awesome. Every single person who's worked with me as an anesthesia assistant has gotten into medical school or nursing school, because I have some nurses that I work with, nursing students. And so that's been awesome. But my current anesthesia assistant just was scheduled for a med school interview and actually had their relative die 2 days before they were scheduled to go to an interview. And so we were talking through that. And so when I say, first of all, I'm really sorry to hear that your mom has passed, Sean. It's a terrible thing to lose a parent, to lose a sibling, to lose anybody in your family. I know how that can be. And what I can say in terms of dealing with this trauma, and I have quite a few videos talking about trauma, talking about overcoming mental issues and mental health and all those kind of things. But the number one thing in overcoming any sort of trauma is to understand what perspective is, what the power of perspective is, and then that perspective is flexible and changeable. This is so important. I speak a lot, I teach a lot about mindset, right? I have my course, The Successful Student Mindset Makeover. When we talk about mindset, what we're really talking about is a perspective. We're talking about the lens with which we see ourselves and we see our world and the connectivity and the interactivity between ourselves and the world. Are we impacting the world, or is the world impacting us? Can I create my future, or is my future predestined? All of these things. Can I grow and improve, or am I what I am, what I'm born as? It's our mindset, our perspective. Moments in our lives, when things happen to us all throughout the day, whatever happens to us is an action. This was done. I was hit in the face. How we react emotionally, physically, and whatever we do, our reaction to that initial action or impact or thing is determined largely by our perspective on that action. For example, you could be somewhere and someone says a comment that, oh, you're going to do it that way? That's not the best way to do this. Your perspective takes what they said, and either you say, wait a minute, is this person criticizing me and being negative? How dare they? Or you can say, oh, this person's trying to help me. That's a really nice comment. I will try this and I'm open to it, right? That's a matter of perspective. It's the same way with traumatic events. And I was giving a talk at UCLA Med School, probably like 8 years ago now. I was giving a talk at UCLA Med School. And in this talk, I was talking about how powerful our mindset is, how powerful our perspectives are, and how no matter what we've been through in terms of trauma and experiences and whatever origins you come from, you can rise above that situation, that circumstance. You can rise above it, but the very first thing you must do is fix your perspective on that and recognize that whatever has happened to you, whatever you have been in your life, whatever actions you've carried out, the bad student you've been, the bad person you've been, the criminal you've been, whatever it is, you have to shift your perspective to say, I can be more, I can be different, I can be separate from that. Wherever you come from, you can separate from that. And in this talk, I was talking about that. And one of the students stood up and said, that's not true. When certain traumatic things happen, you can't separate from that. And I said, no, that's not true. You can separate from trauma, right? That's why we have trauma recovery, we have trauma treatment, and we have behavioral therapy and CBT, and we have all these things. And they were like, no, you can't. And I said, well, what do you mean? Let's talk about trauma, right? And if you guys have ever been to one of my live sessions, I like to get really down to the nuts and bolts. It's real. It's live action. I reveal everything to you guys reveal everything to me, because that's how we get to the core of things. That's how we have real meaningful change. And so I said, well, what are we talking about? And this student talked about how they were raped as a child. And I said, ooh, that is definitely some serious trauma. But I said to the student, I said, hey, I am very sorry that you were raped as a child. But you have the opportunity to change your perspective and recognize that that rape happened to you as a child. And that rape was traumatic, but you don't have to continue to be re-traumatized every day by it. You have the opportunity to put the work in, to strive for more, to study hard, to be consistent, to overcome and use that trauma as fuel to say, listen, I need to study. I need to be effective. I need to get these grades so that way I can become the doctor that I strive to become, so that way I can be a beacon to these other kids who've been traumatized and show them they can overcome, they can be different, they can rise above it. I want to be a beacon so I can talk to these young children when they've been traumatized acutely, and I want to treat them medically and heal them and move them forward from this trauma. And I said, you can shift that perspective to, oh, I can't become a doctor, I can't study because I've been traumatized, to no, because I was traumatized and I know what that is, I must overcome, and blah, blah, blah. And we can talk about that, right? And it was a controversial statement. I don't think it was controversial what I said, but people were saying that I was blaming a rape victim and saying that rape is not something to be traumatized about. I'm like, that's not what I said. But the whole point of this is, and I kind of digress there, but the point of this is that this is not my first time dealing with trauma in students. It's a common thing because life is trauma, right? There's always loss in life. That's why medicine is so important. Healthcare is so important, because there's constantly something going on. And so for you who's just lost a mom, right? And my student who just lost a family member, what I say to you is acknowledge the trauma. Step one. Man, this is traumatic. This is terrible. Don't trivialize like, oh, it's no big deal to lose your mom. It's a huge deal. It's a huge deal to be raped. It's a huge deal to lose a parent. It's awful. It's terrible. Acknowledge it. Sit in it. Feel those feelings. But then allow yourself to shift from all the feelings, all the trauma around it, to pull that out and look at it and embrace it. And this is how it makes me feel. And this is why I feel this way, because my mom was so important to me. She was a beacon, all these things. And then I want you to flip it. And I want you to say, this is traumatic. This is the way I feel. what tools, what mechanisms, what actions are available to me to help me rise from this trauma? Do I need to lean into my family members and let them know how I'm feeling and find community there? Do I need to reach out to a mental health professional and get the therapy I need? Do I need to go and delay some of the actions I was taking with medical school or dental school? I think you were saying dental school. Do I need to delay that a little bit? Do I need to get some more support in the professional arena to help me get through this? Whatever it is, we have to take action to move past it and not just sit in the trauma. So we have to acknowledge it, have those feelings, right? And if we need time, take that time, but look for ways to start moving ourselves through the grief, right? The stages of grief and through the trauma and processing it, not in a dysfunctional way, not in an unhealthy way that holds us down and paralyzes us, but in a healthy, productive, positive, constructive light. To truly process that trauma and move through that trauma and improve and grow from it and be more, right, sturdy as you move through your career. Does that make sense? And when you acknowledge your feelings and why you're feeling that way and what's going on in your life, and then you start to look at action steps and solutions and ways you can move out of that trauma, you're going to get out of that trauma. And it may take time. Give yourself that patience, that self-love, that acceptance to say, you know what? I might need to shut it down for a month. I tell you guys now, sometimes something bad will happen, right? I'll have a crazy patient encounter. I allow myself, even in the hospital, to take 5 minutes and go sit in a quiet room and process what just happened. When I have a crazy shift, I allow myself, I tell my wife, hey, listen, I need to go shut it down and Netflix the day away for half a day. I need to go watch something about space and outer space and get out of this earth to reset my brain. You have a major trauma, I need to take a week off. I need to take a month, whatever it is. And through all this, guys, what I'll say is I'm a person who likes to be solo in isolation, but for many of us, we can't thrive in isolation. We can't thrive in that isolation. We need that support and that infrastructure. And if that's you guys, reach out. Tell people how you're feeling. Please, 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 please never be ashamed to tell people you're going through it. Because I promise you, they're going through it. Everyone's going through it. We all experience it. Don't tuck that inside and let yourself be broken down. Look for people to build you up. All right? Does that make sense, everybody? I hope that's helpful. I hope that answers your question. Sean, are you still on here? Did I answer your question? Did I address that? I hope that kind of helps you. And what I would say is get to my YouTube channel. Go through my videos. I have lots of videos on mindset, on perspective, on dealing with traumatic events, dealing with unsupportive families, dealing with all kinds of issues that face the students. I like to treat the whole student, right? Because life gets in the way. We got to get life under control if we're going to be an effective student, effective pre-med. Yep. And Eddie says, all you need is one good friend. Man, being able to reach out to one good person is why I love my wife so much. My wife, Shannon, like having one person you can reach out to at your lowest moment who won't judge you and who will support you. It's a powerful, powerful thing. So cultivate that in your life, guys. Simpo says, just finished the Prime reading course. Thank you. Did you like it? Did you love it? What was your biggest takeaway? Tell me about it. What'd you think? I've been getting great feedback on Prime Reading Protocol from students. I just pulled it out of my 5 pillars for the first time ever to get people this reading tool. It's incredible, y'all. It's so detailed, step by step. I love it. And the feedback's been incredible. So thank you. I'm glad you just finished it. Thank you for finishing it. So many people, like, they want to do something, but they don't have the patience to get through it. And all of my stuff is so detailed that it can take some time, but I applaud you for finishing it and getting through it, and I'm glad you enjoyed that. Let's see. RJKM says, will med schools favor an applicant with an undergrad BSN and 3 years of nursing experience but little research over another applicant with strong research but lacking clinical experience? So this is a complex question, right? So you put a lot of meat in that question. I appreciate it. Thank you for your question. Will med schools favor an applicant with an undergrad BSN and 3 years of nursing experience but little research over another applicant with strong research but lacking clinical experience? So one of the core things you have to understand about med school admissions is that research is not a requirement to get into medical school. It is absolutely not. However, clinical experience is a requirement to get into medical school. Why do you think that is? Why do you think that is, guys? Because medical school is hard, intern year is hard, residency is hard, being a doctor is hard. It's a field of sacrifice and giving, and a lot of things that you are not the most comfortable. Help people in their lowest moments. And so because of this, if you don't have a true passion, calling, and understand for it, you won't survive. And if you don't know what it is, how can you actually have that passion? And so for medical schools, they're looking for people who have enough experience to truly understand if they want this life or if they don't want this life. And if you don't have that experience, how can you say, oh, yes, I'm meant to be a doctor, when you don't know what being a doctor is? You don't know what the clinical environment entails. And so clinical experience is crucial if you want to get into medical school. And so to answer your question, clinical experience trumps research. However, this is important. No experience is inherently better than any other experience. What elevates that experience in the minds of medical schools is the impact of that experience. What did that experience mean to you personally? How did you grow in that experience personally? And how did you make an impact in that experience to impact someone else or something else or an organization, right? If you can articulate what it meant to you as a person, how you grew, and how you impacted, if you can do those three things, that's what elevates your experience. So if you can have a clinical experience that was personally meaningful, that helped you grow and gain insight into the field, maybe pick up a skill, whatever, and you were able to impact someone, med schools are going to love that. You'll be accepted all over the place. If you have clinical experience and you can't articulate how it was meaningful to you, you can't articulate how you grew and what you learned from the experience, and you can't articulate how you made an impact, then it's an empty, hollow, generic experience, and you come off as a box checker. And because of that, medical schools won't accept you. So it's so important that you understand that that matters. And so two clinical experiences aren't equal. You have to have those three components. And it's the way you articulate that is in your activity section, is in your personal statement, is in your interview, but also, and this is a big component people miss, in your letters of recommendation. So if you're going to have a most meaningful experience, you're going to say this clinical experience was incredible, I did all these hours, and it was so blah, 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 and I made such an impact. Where's your letter of recommendation where you have an authority figure who's not yourself, who has no reason to lie for you, who backs up how meaningful it was, how impactful it was, how all these things were? That's how you really take it to the next level. And so that's what I would say to you. So if you have had an undergrad in BS, if you have an undergrad BSN, you have your Bachelor of Science in Nursing, and you have nursing experience, right? And then in your nursing experience, you've networked with physicians and you've shadowed some physicians and you have a letter of recommendation from a physician, I think that will be very impactful to medical schools. And I have had several nurses transition from nursing into medical school and apply with me and use my application course, use my MCAT course, use my programming to be successful and get into medical school. So it's definitely doable. And I have a lot of nurses who I'm like, don't go do research. Don't go do all the, just apply to medical school. You are there, you're ready, you got this stuff. You can use your clinical nursing background when you do this quality improvement project as another experience that's meaningful in your application. There's all kinds of tricks and things we can do to amplify what you've already done. There's no need to go back and act like an undergrad. You are a seasoned healthcare professional, so lean into that and sell your story and tell your story and let medical schools know why you would be an incredible addition and why your nursing is not something to be overlooked, but is a feather in your cap. It is a lift. It is a boost. It is something extra you bring that's incredible to these medical schools. Did that answer your question? Apparently it did. They said thank you with an exclamation mark. All right. Awesome. Simpo replied back. I asked, he said, Simpo said, just finished your prime course. Thank you so much. And so I said, hey, how was it? What'd you think? And then Simpo says, I'm actually in optometry school and wasn't doing as well as I could. I really learned how to use my brain correctly and not to stuff it with the material. I love that. And this is so important. A lot of what I teach is all about thinking differently, approaching the problem differently. So that way we can be what? Different. Too often we try to follow the cookie cutter recipe, and it doesn't allow us to be our best selves. If you want to be high level, if you want to be an efficient, effective student, it's not always about doing more. Frequently, it's about doing less, but doing that less in the right way. And so in this case, in my prime reading program, I'm teaching people, you don't have to be super smart to be a great reader, to be a straight A student, but you have to use whatever you have correctly. And so this prime is all about flipping the switch and teaching you how to truly prime your brain to read at a high level and to build in this stepwise process. It's super, super powerful. So thank you, Simpo, for enrolling in the course, for finishing the course, and helping yourself in optometry school to be effective and get through the material quickly and effectively and elevate yourself. So I'm so glad to hear that. If there's any of you guys who want to enroll in my prime reading protocol, the link is in the description on my YouTube channel, on the podcast, right? Because it's the Pre-Med Productivity Podcast. I got the podcast available on your podcast networks. We're live action right now. Instagram, Facebook, YouTube. But wherever you're at, the link, if you're on my Instagram, is in my bio. If you go to my bio, my profile, you click there, you'll see my primary protocol. It's discounted. It's a discount link because I want to serve you guys. I want you guys to be uplifted. I want you guys to have the experience Simpo just had where you feel like, man, I should have been, this is ridiculous. I should have been doing this all the time. I could have done this. I had the same brain, but now my brain is effective. It's in the right place to be effective and get to the scores I need. So I'm so happy to hear that. Thank you so much. Right now, guys, we're answering questions that you guys submit. So if you have questions, guys, I'm on here. I'll answer them because, again, I'm here for you guys as students. That's what it's all about. So if you have questions, put them in the box and I'll get to them. Exodus says, what do you think PAs have or could have in improving, what role, I think that's what you mean to say. Oh, there we go. Yeah. What role do you think PAs have or could have in improving our healthcare system? I am a current PA student graduating in December, and I want to get involved in healthcare policy. So thank you for your question. I have several videos talking about mid-level providers, PAs, NPs, CRNAs on my YouTube channel, so check those out. I want to say right from the start, I am not a mid-level provider. I'm a physician. I'm an MD. But I fully value mid-level providers. I feel like we need mid-level providers. We have a shortage of care providers. So I am fully encouraged. I think it's awesome you're in PA school or applying to your NPA school. I love that. I think there's a huge role and a huge need for PAs, NPs, you name it, mid-level providers. However, I am against mid-level providers telling themselves, telling patients that they are the same as a physician. You are not, they are not, I don't care, you're not. And I feel like it's misleading, and I feel like it's frankly dangerous to act like that. Why? Because it misleads the public, but it also misleads yourself in the sense that what it leads to is we have mid-level providers practicing outside of their scope. And in any industry, right? This is why physicians specialize, right? You don't want your primary care provider doing open heart surgery. You don't want your orthopedist doing open heart surgery. Everyone needs to practice within their scope. As mid-level providers, stay in your scope, stay in your lane, and within that, the way that I feel like mid-level providers can really help our healthcare system is by understanding your scope and understanding where you're at, working as part of the team model to say, listen, it's not mid-level providers versus physicians. And it's the same way for physicians. It's not physicians versus mid-level providers. Let's cut the animosity. Let's keep the main thing the main thing. Like in politics, right? You got all these people trying to skirt the issue and have you focus on this, and we skirt the main issue. If you are a PA, if you are an NP, if you are a CRNA, if you are a physician, we are all here to serve patients. We all got in this field to sacrifice of ourselves for our patients. We have to put the patients first and stop fighting amongst ourselves and turn our angst and our fight and our battle against the real issues. Insurance company policies, right? Hospital staffing policies where we're understaffed, overworked, underpaid, under-resourced. We need to focus on those enemies and not the enemies within the care provider community. I think that's so important. And as mid-level providers, just as physicians need to do, right? All my future doctors here, it's the same premise. Future PAs, future NPs, future MDs, DOs. You need to use your training to train yourself to the highest of your scope, to the highest of your profession, the highest level of excellence. We cannot be a society of mediocre ass providers. And as someone who works in healthcare, it makes me sick how many mediocre providers there are in our healthcare system who did just enough to get the degree, just enough to get the certification, and haven't worked to maintain that standard and continue that lifelong learning trajectory to provide excellent, up-to-date, accurate, high-level acute care to patients. So if you are in PA school, use that PA school to train to the maximum of your ability and learn it all, the physiology, the pharmacology, learn it all so that way you can give your patients the highest standard of care. Not just this gets by. Push yourself, guys. Take on extra cases. Read about your patients. Read about conditions. Stay up to date in the literature, guys. Do all of these things. Become the best, guys. Strive for excellence. Like we talk about no excuses, just dominate on this channel. Strive to be a dominant PA, a dominant nurse practitioner, a dominant doctor. Not just, oh, he's all right. Right? Be the doctor or the PA when you walk in the room. The patient's excited. The family's excited. The other provider's like, oh, yeah. When he's on service, she's on service, we rocking today. We winning. That's what you want. Yep. Did that answer your question? And also advocate. Again, turn the angst where it should be. Yes. So Erasmo says, can you tell me the difference between a CRNA and an anesthesiologist? I'm in college and want to know about these careers. I have a fantastic, I think I did 2 videos series talking about anesthesia careers and the difference between a CRNA, an anesthesia assistant, and a physician anesthesiologist. It's fantastic. It will go into great detail. So go check out that video on my YouTube channel. Search for it. I think it was like a month and a half ago I did it. But it's a full breakdown, just like we're here an hour and 15 minutes. That's also a full breakdown of all those differences, the training differences, the scope of practice differences, the salary differences, the scope and the career outlook so you can plan out, right? Because I'm here to teach students, so I talk about all those issues that are specific for students and that you want to know. So check out that video. Let's do a couple more. Yeah, Eddie. Yeah, for sure. Come down. Let's have lunch anytime. I can't believe you're already in step 2, man. Time is flying. I hope everything is going well. Send me a text right now. Update me, man. What's going on? How's med school treating you? I know you're rocking it as always. I'll point this out. So Eddie's on here right now. Eddie's one of my students, been with me for a while. And Eddie actually found me. I was at a conference giving a keynote. And after all my keynotes, just like we're doing here, when I do speeches, workshops, whatever, they might book me for an hour keynote. I always over-deliver. Like I talk about over-preparing for your specialty, I always over-deliver. So whenever I do a keynote, whatever, I'll step off stage and I'll take questions until people leave. So I've literally shown up at a place and done a 9 a.m. to 10 a.m. keynote. I've been there at 5 o'clock still answering questions. I'll sit down with you. We can diagram it out. Whatever wisdom I can impart to you, I will do. And so Eddie was one of the students who came up to me after I got off the stage and was just like hovering and followed me around. I was hovering. He's like, listen, Dr. Pinesett, I don't know what you got going on, but it's like, but your talk today moved me. I've been following your channel for a while. Like, I got to get with you. Like, can I talk to you? And I was like, listen, I got to go. I'm hosting a dinner for my students who are in my program right now. Is it, can I come to dinner? And I'm like, it was a bold ask, but I love people who are bold, right? That knows you just dominate. And he asked me that. I was like, of course. And so we actually went out and we had garlic crab. We went to a place in San Francisco and had garlic crab. And I had like probably like 20 of my students and we pigged out. It was incredible. But that's how I first met Eddie. And then Eddie came aboard, got into my coaching program. I got to know Eddie personally really, really well. And fast forward, Eddie's in medical school now and doing great and all that kind of good stuff. But it's an example of, I want to point to Eddie for this reason, is that I knew when I met Eddie, he was going to be successful. And the reason I knew he was going to be successful is because he was bold. He was not afraid to say, I need help. And he was not afraid to reach out for that help and say, no, whatever I got to do, and follow me around and say, I'm going to dinner with you, all those kind of things, and show up to coaching and to take hard coaching and to hear, you're not perfect. You need to work on these things, and was willing to take that feedback. And then once he heard the feedback, not get angry, but embrace it and move forward and fuel his journey. And as a result, and he turned around. I remember when he called me and left me a voicemail, hey, Dr. Pinesett, I got into medical school today. Oh my gosh. And it was like this great celebratory moment. But I knew he was going to be successful because he had the mindset and the perspective for it. We were talking about earlier. So you guys as pre-meds, as students, be open to feedback. Look for feedback. Seek out tough coaches, hard asses like myself, who will yell at you and treat you that way. And Eddie was receptive to this because he's a former athlete, so he's used to hard coaching. And so we got along instantly. But look for people who are going to tell you the difficult thing, who aren't just going to sugarcoat it for you, and tell you the real thing and tell you, listen, you need to work or you need to do this. And because that's how you're going to get ahead and get there. So I just wanted to put that teaching point out there for you guys. Couple more questions and I'm leaving. Husbeat says, I want to second that. As a nurse, I see a lot of folks coming back into my facility. They exhibit better health and the insurance companies kick them out. Wellness and health prevention. Yeah, it's like, it's crazy, guys. We've got to stress preventative health. We've got to stress wellness. We've got to stress going in for your annual physicals. Man, I just saw D'Angelo. Who saw this? D'Angelo just died of some sort of gastric something or other. And we see Chadwick Boseman, who played Black Panther, and Jackie Robinson. We see a lot of people in all communities, but particularly in the Black community, dying of these conditions that, are catchable, right? We can surveil for these things, but we're not going in, we're not getting checked, we're not getting the routine visits, and then we're not popping in until something bothers us. And so I encourage everyone to get your routine checks, get your physicals, show up to your doctor, catch those innocuous things early on in the process, because medicine is great right now, y'all. We have so many great tools to treat conditions, but if you don't know you have a condition, how can you get the proper treatment? How can you get that treatment early? So please go, guys, get your physicals, get checked, and emphasize that preventative health. RJ Kim, to your last little comment here, I would say watch that CRNA video when I talk about work-life balance and responsibilities in great detail and scope of practice for CRNAs versus physicians. So I won't bore us with that. I've got to go, guys. I've got coaching tonight with my course students. If you are interested in personalized coaching, guys, get enrolled. Get to my website, premedproductivity.com. Get into a course. Get into a coaching program. Let me help you unlock your potential. Let me help you flip that switch and see that you can be more. And let me show you the way to being more and being your best self, guys. I thank you so much for joining me. I'm going to be live action, guys, every single Monday, every single Wednesday across my social media channels. So make sure you subscribe, turn on the notifications. If you have questions, even after this video, I'm here for you guys. I will start doing what I call, I've seen this popular on some of the podcasts that I listen to. I'm like, oh, that'd be a great thing to do with students. Like, in addition to answering questions at the end of my live streams, I'm also going to start doing mailbags, where I go through my comments on my YouTube channel, previous comments people have left. I'm going to pull all those comments together like we're doing here, and I'm going to answer those questions and bring those to you. So that way I'm always educating and always meeting you guys where you're at, providing real solutions to your real problems. That's what it's about, guys. It's about real expertise, real people, and real empowerment, and getting you guys to your real world success. So I thank you guys so much for joining me. We're at an hour and 23, gosh darn minutes. If you have enjoyed this, if you like this, take a second, like this video right now, comment, say, Dr. P, thank you for after your long shift. I didn't have time to even change out of my scrubs into my period productivity apparel, my No Shoes Just Dominate. I came straight in. That's why we were late today by a half hour. Let me know you appreciate me being here. Let me know you learned something today. You were uplifted today. You feel like you're one step closer to your goal. Take a second and share this with someone who could use some of this empowerment today, guys. And yeah, I'll see you guys next time. Live action, y'all. Have a great day.